Welcome to Recover Stronger, the show that gives you high-quality information about injury and rehabilitation, performance, and health. My name is Noah Mandel, and I'm a resident physiotherapist from Toronto, Canada. I created this podcast to provide you with educational content, not medical advice. Please seek advice from a qualified healthcare professional if you are currently dealing with a health-related concern. If you enjoyed the podcast, please consider leaving a review. I would deeply appreciate it, and you would also be doing your part in helping the podcast grow so that we could provide this information to more and more people. Hello everyone, welcome to Recover Stronger. Today I had the absolute pleasure of speaking with the one and only Adam Meakins. I have such a deep respect and appreciation for Adam. He has been in the physiotherapy world for over 20 years, and thus he has such an abundance of knowledge. We discussed many things, such as when physios are useful and when we are not, why strengthening a muscle isn't always the answer to recovering from pain, what it looks like to take a holistic approach and treat the whole person rather than just a painful body part, what Adam would do differently if he started his career over, and much more. I've learned a lot from Adam over the years, and today's conversation was no different, so I really hope you enjoy it and you learn something as well. And without further delay, I bring to you
Adam Meakins. Thank you very much for coming on the first episode ever of Recover Stronger. It's much appreciated. If anyone is not aware of who you are for whatever reason, if they're somehow in the rehab world and they've been living under a rock, would you mind telling everyone a little bit about yourself and who you are?
Yeah, sure. First things first, Noah, thanks for inviting me on to your podcast to be the first guest. It's quite a privilege and an honour. So I wish you well with it. I hope this isn't a bad start and it stops after this episode.
Hopefully not. Yeah, well, much appreciated for you coming on for sure.
No, well, as I say, it's appreciated you asking me on. So a little bit about me in a nutshell, mate. I'm a physiotherapist. I've been now for 23 years now, I think. Haven't always been a physio, so don't let these youthful looks fool you. I've been around the block a few times before. So before I went into physiotherapy, I did my first degree in sports science, exercise science, worked as a strength and conditioning coach for a couple of years before I went into physiotherapy. And as I say, I've been plugging away as a physio for the last 2 decades. And, on social media, I've developed this reputation for being this grumpy, cantankerous, critical, skeptical, controversial person as well, that sometimes gets himself into hot water because he does engage his mouth before his brain sometimes, and does get quite frustrated and vocal about stuff. And I do tend to not hold my punches sometimes when I'm a bit critical and a bit frustrated about things. And as over the years generated quite a lot of discussion and debate, which I'm hoping in the grand scheme of things is more for the good than the bad. I guess it depends on which side of the argument you're on as to whether you agree with that or not. But yeah, that's me in a nutshell, mate.
A little humble. You've been a physio for a very long time, but you also have your hands in, some research papers. You've written maybe, how many blogs do you think you've written over the years?
Well, that's a good question. Probably about 150, maybe 200, I'd say.
That's a ton. And as you were saying, a little bit of some strong opinions, stronger language on social media. But when you really dissect a lot of these claims, even if you are on the other side of them, I do think that it is for the greater good in the end, because if you are able to maybe not get quite as offended from some of the language and you really dissect what you're saying, a lot of these things are very thought-provoking. They're from a reasonable stance. They're well-researched, of course. So I think sometimes it might come off as very controversial, but when you really get into the nitty-gritty of these things, it's pretty reasonable in my eyes.
Well, I appreciate you saying that, and it's nice to hear that when people do stroke my biases a little bit and give my ego a little bit of a boost. So no, I do appreciate that. But yeah, as you say, it can be quite hard when we are being critical to try and separate the critical thinking aspect of it from criticism of ourselves. So I do understand why a lot of people sometimes take things personally, because nobody likes to feel like they're being critiqued and criticized. And when people are questioning a lot of what physio do, which is what I do a lot, and about our interventions and our treatments and our methods, and not perhaps being what we thought they were. I can understand people sometimes taking it personally. They shouldn't, but I do understand when they do. It's a normal human reaction. And over the years, I think, I've just realized that, I try to give people a little bit of, leeway to understand, yeah, okay, you've taken it personally, you shouldn't have, but it's a normal human reaction. And, I'm just going to let that simmer. I'm just going to let those thoughts just brew. I'm going to let that dust settle, and then we'll come back to it and discuss it when things are a bit calmer. And that's something that I think maybe maturity and a bit of experience has led me into understanding normally works a bit better now on social media.
Yeah, a lot of practice too, getting on people's nerves. So I mean, it's and that's something that you have done as well, like on your own end, letting things simmer for a little bit. Because I've heard you change your mind about things over the years, which in my mind is always something that I really, really appreciate from people that have been in the field for a very long time. Because it's never a good sign when someone has never changed their opinion in 2 decades of being in a practice, in spite of new evidence constantly coming out. So
that blows my mind when people see that as a negative, when people see that as, as a sign of weakness, to say, hold up a minute, I've thought something a bit differently. I'm going to do something a bit differently. People, you're an idiot. You're stupid. You're ignorant. And I'm like, no, it's actual positive trait. If you're still thinking the way you were 5, 10, 15 years ago, that's the negative trait, because nobody should be thinking like that. There's always things that change with more information that we learn, and say just being a bit more humble and appreciative of this normal human trait that we have of changing our minds and opinions. It's not negative, it's a good thing, it's a strong thing to have, and nobody should be ashamed of vocalizing it. But again, I think it's that social media effect. Nobody likes to admit they're wrong. Nobody likes to admit they don't know anything anymore either. That's as well, that pisses me off a lot. Again, that's another thing. A lot of people think that's a sign of it's a negative trait to say, I don't know. I'm like, no, it's a strong trait. You got to have humility and honesty to be able to say, I don't know.
Absolutely. Yeah. For any, sorry, go ahead. What was that? The last part?
I was just saying, it's just human nature. How, we've got to just understand, we have our innate inferiority complexes that we all got to try and overcome. And as I say, don't be ashamed of changing your mind, saying I got that wrong, I'm doing something a bit different now, I'm thinking a bit different, or I just don't know what's going on. There's nothing wrong with that. It's a perfectly good position to be in. It's a strong position to be in. It's a humble, honest position to be in.
100%. And for any of the young physios that might listen to this, that's something that I've used. The critical thinking doesn't end here, but if you're ever vetting someone to see if they're a good source of information, if you have seen them change their mind on things, if they vocalize that they don't know things, it's usually a positive sign that they are well-read and sort of know what they're talking about. Of course, you have to take it a little step further and don't stop the critical thinking there, but that is always a good sign.
Absolutely.
So, speaking of confusion, things changing in physio, minds changing over the years, there is a lot of confusion among the public, but also among physios themselves about what we do. And I remember going into physio school thinking that I was a healer and I was going to fix people. And it didn't take too long to stumble across your podcast and start to having some of my views and challenges my beliefs challenged. And at first, of course, a little bit painful, but over the years, it was a really great process. But initially, I had this sort of sense of dread. Like, oh no, I'm not fixing people. I'm not helping people. What is it that I do? Am I useless as a healthcare practitioner? So that's the first thing I sort of wanted to get into with you, Adam. What is it that physios actually do, and what do we not do?
Yeah, it's a great question, Noah. And first things first, I can totally empathize with those feelings because I've gone through them as well. And any good evidence based physiotherapist over the last 20, 30 years will have done the same thing. Because, we all get taught or led to believe that we are doing things that we perhaps just aren't doing. And, that realization can hit you like a ton of bricks. It can be like a bloody steam train coming down the tracks at 100 miles an hour and just wipes you out, makes you feel silly, makes you feel stupid. It can make you feel worthless. It can make you feel redundant. And you can get very demoralized. And I did. I very much got myself into this little bit of a deep well of, oh my God, what am I going to do now? What's the point of my training? What's the point of my career? Am I going to continue on with this now that I've got all this demoralization and uncertainty about what I do and how I do it and all that sort of stuff? So, I totally empathize with any physiotherapist going through that process currently or have gone through it in the past. But again, I try to put a bit of a positive light on that and say it's a good thing to go through that. I know it may not feel like it at the time, but it is. The ones that don't go through that, they're normally the clinicians that I find are not normally the better clinicians. So the ones that have had this very discouraging, a period of time where they do feel worthless and redundant, I say to them, it's eventually you'll come through the other side of it and see it as a good thing eventually. How long that takes, who knows? But to answer your question, you're right. Yeah, we are not fixers. We are not magicians. We are not speeding up the healing processes. We're not correcting imbalances. We're not changing dysfunctions. The role of what we do, the worth of what we do as physiotherapists is help people understand pain when they don't understand it. That, in a nutshell, is pretty much what a good physiotherapist or any other musculoskeletal healthcare provider should be doing. People have pain that they don't understand. You wake up one morning, you got back pain, it's scary as fuck. You're like, what the hell's going on here? Or your knee starts hurting when you're training for a run and you're thinking, why is my knee starting to hurt? And so, you've got this uncertainty, you don't know what's going on. So what do? You go and find somebody who's going to help you understand what that pain is and hopefully give you some reassurance about what needs to be done or how long it's going to take to get better. And that, in a nutshell, is what a good evidence-based healthcare clinician in musculoskeletal should be doing. And there is a shitload of worth in that. There is huge value in that. And I tell, all young physios, don't demoralize yourself in thinking just giving people information and reassurance is insignificant, because it isn't. It's the major part of what we do. Shift your expectations and start to realize you're here to help people be reassured, understand their pain, move despite their pain, build up resilience and robustness despite their pain, whilst natural history is working in the background. Because again, at the end of the day, we don't really change the natural history of many things we see, and there's nothing wrong with that. That's not a bad thing. That's just what human anatomy and physiology has evolved to do over hundreds of thousands of years, to help itself get back to square one eventually. We are just facilitating that. We're reassuring, encouraging people that is what's happening. And then perhaps, the other little bit we can do whilst people have come to see us is maybe talk about other things around the patient's lifestyle, maybe start, sprinkling a little bit of behavioral change stuff in there as well, which, if you can do that, absolutely wants to be lauded, wants to be praised, wants to be shouted from the rooftops, because that isn't an easy part of the job at all. It's the bit that I try to get, healthcare clinicians to really start to value, that if you can convince somebody to, because they've got this pain and they've come to see you and you've reassured them, but you've now managed to talk to them about their sleeping habits, their diet, their smoking, their consumption of alcohol, their exercise levels, and you can change that by 1%. You may ask them to walk a little bit more, go to the gym once more than they normally do. If you can convince somebody to stop smoking, that is a massive achievement. That is a huge achievement, because people don't change their behavior very quickly or very easily. So, if you can do that as well, that is, again, another great string to your bow as a healthcare clinician. So, again, that is basically, in a nutshell,
right,
what we should be doing.
It's such a good point that we are in a position where we could help facilitate positive behavior changes, when unfortunately there's a lot of the opposite in physiotherapy, which to the layman might sound very shocking that you could go to a healthcare professional and potentially be worse off in some ways because of it. But with some poor beliefs that a physio might have, they might project those beliefs onto the patient and might cause behavior change that's negative. Like if they tell them that they shouldn't move in a particular way, they might create some fear around moving. So on that notion, when do you think people maybe don't need physio, or when should physios potentially cut off care with the patient?
Now that's a great question. I think, we are here to help people as much as they want or need to be helped. At the end of the day, I always try to put the ball into the patient's court when it comes to how often they want to be seen, or how often they want to consult with me, because at the end of the day, that's what we're here for. We're here to offer that service, that consultation service. That some people may feel like they're getting dependent and reliant on some of the interventions and treatments we do, and that's where I think there's the negative side of it. That's where there's that iatrogenic harms that I think happens a lot in physiotherapy, where people get dependent on the interventions. But I'm more than happy to see people as many times as they want, to talk things out, to discuss things, to reassure people. So, I very much have this open door policy with all of my patients. I'm here for as much or as little as you want. All I'm not doing is getting you dependent on interventions or treatments. I'm here to be a soundboard for you to get frustrated with and say, I'm concerned about what's going on. I don't know what's happening here. I'm frustrated. It's not making as much progress as I thought it would do. That's what physios should be doing. And that's how much, again, depends on the patient as to how often that happens. But as I say, it's just not overdoing all the interventions and the passive modalities and the treatments and the other sort of bullshit that infests our professions. And that, again, that's that shift from moving away from feeling that you're fixing, that you have to do something to help somebody. And again, it's a cultural problem that physio's got. It's synonymous with doing stuff. The physiotherapy profession, you go and see a physio and you're going to get something done. And until that is changed and shifted culturally, there's still going to be a desire and a push to do things. But, as long as you're not getting people hooked on those things and you're there to say support, reassure, offer advice, everything, then keep that open door policy. I think there's nothing wrong with that at all.
Mm-hmm. Right. It's, nothing. It's not like giving someone a massage is an evil, nefarious thing to do. But when they become dependent on it and they think that you are healing them with that massage and that they need it in order to get better, that's when it is potentially an issue. And I think that's where people strawman your argument against manual therapy sometimes.
They do, but they do also have a good point that there is very little evidence about the dependency effect on interventions in physiotherapy, and it is a woefully under-researched area. Now, I normally hate this saying because this saying is used by quacks to abuse the fact that there isn't evidence on stuff, but there's this saying that, absence of evidence isn't evidence of absence. And I truly do think this is the case with dependencies on a lot of healthcare, not just musculoskeletal physiotherapy, but a lot of healthcare. There are a lot of iatrogenic, nocebic, dependent type problems that occur because I witness it clinically daily for 20 odd years. And you should never trust your own clinical observations. I know that because there's issues with that as well. But it's just a woefully under-researched area. And it's a very challenging area to research because, it has lots of barriers to be able to how to do this well, to see whether our people are getting adverse effects from our interventions, our treatments and our advice. But I do think more time, energy and research needs to be directed into that to look, because we always tend to focus on what physiotherapy can do from a positive aspect, but we'd never very rarely look at the harms and the detriments and the side effects of our interventions, our advice and our treatment. And I think we should. And I think we need to find that balance of not just looking at all the positives and the things that can be affected with, our interventions, advice and guidance, but also perhaps the other side of the coin as well.
Yeah, that's actually very, very insightful. I never thought about it that way. But when you look at the research, it's always looking for an effect of an intervention.
Yeah.
It's very rarely looking at,
the reported harms and the negative effects are very rarely reported in many randomized controlled trials. Very, very rarely.
Yeah.
And and then very rarely are there seen to be research trials that look at the effect of wording things differently, saying things differently, and what people's opinions are, what their behavior does or doesn't change when we say things or word things slightly differently as well. That very rarely happens.
Yeah. And when they do report any adverse outcomes, it's usually in about 2 sentences in the paper, and that's
Absolutely.
about it. Yeah. Okay. So we spoke about, that open door policy, which I think is great, because a lot of people think that, that there's no need for physios if people are going to heal eventually, but some people do need that reassurance. So those are some people that are great candidates for physiotherapy, people that really need to have a chat with you, figure out what's going on, have some reassurance, and help be guided while they're injured. Are there other, perhaps maybe, conditions that you think really benefit from physiotherapy and that do need some active care? The first thing that comes into my mind is somebody who is recovering from maybe a traumatic injury or from surgery. There's a bunch of ways to go about this, but do you think these people are good candidates for physio?
It's a great question again, Noah, and I think I'm going to answer it in a slightly roundabout way, like I tend to do, rather than get to the point, a bit like a politician. I don't think there's any specific conditions, pathologies, surgeries that definitely need 100% of the time physiotherapy. But I do think there are individuals who need physiotherapy, and then there are individuals who don't need physiotherapy. So I think it's more about an individual factor rather than the pathology or the pain or the disability or the surgery that they've had. And I think it all boils down to, say, understanding, knowledge, and that good old word that we like to throw around a lot, self-efficacy. Mm-hmm. If somebody's got high self-efficacy with back surgery that they've just had, a discectomy, they probably ain't going to need much physio, if any physiotherapy at all. They're probably going to have a good outcome because of those other factors, their high self-efficacy. However, if somebody's had exactly the same surgery, but they've got very low self-efficacy, they're uncertain, they don't know what's going on, then they are probably going to need a lot more of our help and assistance and reassurance and guidance. So, yeah, I think I'm going to answer that question, say, in a rather roundabout way, and say, no, I don't think everybody after surgery needs physiotherapy. I've known many knee replacements have their knee replacements and just fuck off and get on with it. My dad being the classic example. So my father recently had a knee replacement. I mean, he's a stubborn git anyway, and he knows my feelings on physiotherapy. And he's been exposed to me ranting and raving for decades about all the issues of physio. So he's got very little reassurance that he's going to find a good physio, but he knows what to do. He's been, well exposed to exercises through all his life. He had a knee replacement. He didn't go and see a physio at all. He just cracked on and got on with it himself. But then there's other people that have had knee replacements that do really need and value their regular weekly input with a physiotherapist to monitor their knee bend and to give them some encouragement that they're on the right path and it's going to get there. And yes, it's taking longer than you anticipate and expect.
Mm-hmm. Right. Yeah, I struggle to find something that I would go through myself where I would seek out a physio. And I know you had your back injury a couple of years ago as well, and you didn't seek treatment for that either. And I think a big part of that is because we possess the knowledge and perhaps, as you said, the self-efficacy to manage these things on our own. Like if I was to tear my ACL, for example, I have a lot of knowledge about how I could get back to functioning. So I think there's potentially still a need. I'd actually like to ask you this, but I think there still is a good need for a good rehabilitative program. But I think some people can create that on their own. Some people don't need a physio to do that.
Absolutely, and with technology and artificial intelligence nowadays, and Google and ChatGPT, people can do their own research and become, self-educated around a lot of these things. And of course, there's always going to be the issues: are they getting the good information, or are they getting the bullshit information and the wrong information out there? Of course, there's always that risk. But who's to say that the physios that are telling them aren't also getting the wrong information onto them as well?
Yeah.
But yeah, no, I think it's great. Again, it's all down to your understanding of the situation you're in and how much control you feel over that. I had a perfect example of this not so long ago. I found myself in a situation that I had zero self-efficacy over. So I got a warning light on my car as I was driving it. Scared the shit out of me. It started blinking on the dashboard, and I'm like, the fuck is going on here? Absolutely no idea what to do. So, panic stations, driving really slowly, shuffle it into the local garage and say to this junior mechanic who was about 22 years old, look younger than you, Noah, fresh face, comes out, picking his nose. All right, mate, what's the problem? I said, I've got a warning light on my car and I don't know what to do. And he looked at me up and down like absolutely disgusted. A man of my age didn't know what was going on with the car. I said, all right, leave it with me. And a couple of minutes later, got a little device out, plugged it into the engine, pressed a few buttons, go, nothing to worry about. It's all okay. You're good to go. And I was like, what? And it's like, yeah, it's just one of these little things, it's nothing to worry about. I've reset the computer. It's all okay. You're good to go. So, a perfect example. I had absolutely no fucking idea what to do. Absolutely clueless. Go and see somebody who does know what they're talking about and what to do, and get sorted out very easy. I didn't appreciate the up and down look and the looks of disgust. I wouldn't recommend healthcare professionals do that with their patients. But again, it's just a perfect example of how we only know what we only know.
That's a great metaphor. Yeah, it'd be terrible if someone came in, they're in so much pain. It's like, oh, you don't know how to deal with this yet? How old are you?
It's fucking back pain. What do you mean you don't know how to do it? What are you in my clinic for? Fuck off, get out of it. It's going to be all right in 6 weeks. Yeah.
Yeah.
Don't do that with your patients.
Definitely not.
No.
Yeah. No, that's not the point of the podcast, to teach people to give the up and down look. It's the opposite. So Adam, switching gears a bit here, your catchphrase used to be, you can't go wrong getting strong. It's changed to, you can't go wrong trying to get strong. What is with
it's
the
still
change?
On the t-shirt, the old way.
So I know we're expecting the politician answer here because you love your strength training, but why is that distinction important?
Yeah, another great question, mate. And again, it's because I've changed my mind, and it's a process of evolution over the years and reading more research to realize that exercise mediates pain and improves function without getting people stronger. So you can throw exercise at somebody with back pain or with a knee problem or with a shoulder issue, and they get better. Their disability reduces, but their strength will not change one iota. And that's probably because the exercises haven't reached the level of intensity or dosage to actually create any strength changes. But, they still feel that the exercise is being beneficial. So I think that's the main reason as to why I've changed that little slogan. I still think strengthening or resisting, I've actually changed the term now. I very rarely tell people I'm giving them strengthening exercises. I give them resistance-based exercises because I don't think we need to hit the criteria for those resistance-based exercises to be strengthening for a lot of people with pain and disability. Sometimes we do, all right? I'm not going to say it's never. There are some situations and some individuals that do need to improve their force output of a set muscle group. And their power and their impulse or capacity or endurance or whatever else you want to call it, those terms we use a lot. But no, I just think, it's a case that a lot of people, the exercise mediates their pain and disability through other mechanisms other than their muscles getting stronger. And there's nothing wrong with that. It's confusing. It's, again, a bit frustrating because we haven't got the simple answers that we thought we had. But it doesn't mean that exercise doesn't work. I've seen a bit of a kickback against exercise recently. And again, it's a bit frustrating with these people going, oh, see, I told you exercise isn't all that. It doesn't work. I'm like, no, it does work. Of course it fucking works. It just doesn't work the way we thought it does. It's no different than manual therapy. We thought manual therapy was releasing the fascia, reducing the toxins in the muscles or pushing the joints back into place. We've realized that it doesn't do that, but it can still mediate people's pain. Exercise, we thought, was, improving muscle strength or increasing tissue tolerances or actually creating some structural changes to the tissues to help their pain and their disability. And we've realized a lot of the time it doesn't, but it is still helpful. It is still a great treatment. In fact, it's a hill I'm prepared to die on to say it is the one treatment that I think pound for pound has so many benefits and very, very, very little side effects that I think we should be advocating it and promoting it to everyone we see for every problem they've got. There's just lots of options and varieties and ways of getting people to do it. And that's where it all comes down to the individualized, tailored, patient, person-centered approach with using exercises. Get rid of those pre-printed, photocopied sheets of exercise protocols. Fucking throw those out, because that completely devalues the individualization of exercises. And I think that's a huge barrier that I see a lot of patients saying, oh, all I got was a shitty sheet of exercises. And the patients don't feel like there's any individualization or commitment to do these exercises. They feel very devalued because of that. I use a lot of the same exercise with a lot of people I see. They just don't know. They feel a lot of the time that it's been tailored specifically for them. And it has to a certain degree, because I still think a lot of the exercises I give people, although they're the same, there's a lot of difference in the parameters, in the dosages, in the intensities, in the frequencies, and the reasons as to why I'm giving these exercises.
Absolutely. There's so much to get into there. First off, yeah, it is confusing when you give someone a strengthening exercise, and even if they get stronger, that doesn't necessarily mean that that strength helped improve their pain recovery, which is very confusing. But the old saying, like, correlation is not causation, that's where that comes in. And yeah, when you say that, oh, strengthening isn't the mediator for recovery, people will take that and say, oh, okay, so nothing matters then. And just because something doesn't work the way we think it works doesn't mean that it doesn't matter anymore. And that's a common issue that we face. So something you got into there was individualization, and that sometimes it is important for people to actually get stronger. I think when we perhaps don't think that people need actual strength gains in order to get better, that might open the door for some more individualization with their exercises. And we perhaps don't need to think of classic bodybuilding or strength exercises that you might do in the gym. But in what situations do you think it is important for people to actually increase their ability to produce force?
Great question again, Noah. I think there's a lot of benefit in getting the older population stronger. So that is a very much a population who I see that I do think there's a lot of barriers. There's a lot of negativity about engaging with resistance exercises. But I do think, a lot of these individuals with their aches and their pains and their disabilities, their functional deficits, can be hugely improved by getting stronger. I think that's a population that I do think a lot of the time we perhaps do want to be trying to get their force output of their muscles stronger to help, reduce their risk of falls, to, improve their, quality of life, and just to, stop them declining as they age as quickly as they may do if they weren't as strong. So, that is definitely a population. A lot of the time, I think, our exercises could be a bit more specific in trying to improve muscle mass and strength because of all the benefits it has there. And then again, I suppose in your sporting rehab and injury and stuff along those lines, again, that population is also going to be a group that are probably going to need to get their strength recovered before they start exposing themselves to situations there. There's going to be high forces and high demands placed on their bodies, in sporting environments. So again, those individuals also need to have restored their force capacities and their endurance and their power and the rate of force development before they start putting themselves in risky environments to reduce their risk of re-injury. Although, again, it adds confusion here because we are seeing, again, some research that says it's just not that simple either. As much as I think all ACLs need to restore their quad function and, shoulder dislocations need to get their internal, external rotator ratios up and all those sort of things again before they start putting themselves into rugby tournaments and stuff, we still see high rates of re-injury in these populations, even though they've got these figures and they've got these targets achieved. And that's because injury risk and predicting injuries is a hodgepodge minefield of very much a lot of confusion and uncertainty, and it isn't just as simple as getting people stronger and they don't get injured. I really fucking wish it was, because it will make our jobs so much more easier. You could just say the way to reduce injury as an athlete is just get stronger, but we all know those very strong athletes who still get fucking injured as well.
Yeah, of course. This is what we were saying earlier, how some physios even are confused about what we do sometimes. So when someone comes in and we're dealing with knee pain and we're doing maybe a quad exercise, for example, and they're saying, oh, so will strengthening the quad help maybe make the tendon feel better? And it's so hard because I don't know. I don't know what's going on. I don't know why you're getting better. But so they don't realize the can of worms that they're opening up here.
Yeah.
But
a simple obviously, question like that should have a simple answer, shouldn't it?
Right. Right. It should. So it's maddening sometimes. And if people could provide a simple answer for those things, I encourage you to get more confused and join us, because although it sucks, there is truly a lot to be confused about, which, as you mentioned earlier, isn't necessarily a bad thing.
No, again, I think, being confused and uncertain, once you get through that despondency and that very much, oh my God, I'm stuck in a rabbit in a headlights, you get that paralysis by analysis. Once you get through that, it actually realizes it keeps you on your toes. It forces you to go and read more and to try and find and figure things out. And it just keeps you motivated to keep trying to find the answers. Sometimes it does get frustrating because you think, fuck, just as I thought I got a handle on it, this one comes in and just confuses things a bit. But then you go, okay, well, let's go back to plan B and let's see what else we can find. So it's a good thing. It keeps you motivated.
Yeah. I also think, at least for me, this uncertainty, in a weird way, I could flip it to turn it into confidence as a clinician, because when I learned that it's not so one-dimensional, that we have to get people stronger in order to get them to feel better, that might open up the door for more possibilities and more avenues. We might be able to not be so one-dimensional with our treatment options. So I have my bias, and I think we share it. Resistance training is great because it has so many secondary health benefits. And this is what you were saying earlier, that exercise is that one treatment option. It's that hill that you would die on because it's so good for providing these secondary benefits. And people that are in pain are people, and we could all benefit from exercise, of course. Now, this might be a tricky question, and I know I'm confused about it, but when people are in pain and we want to give them exercise, and it's not this typical resistance training exercise that we know puts on muscle mass, can reduce insulin sensitivity, increase insulin sensitivity, and et cetera, et cetera. Can people still get health benefits from other forms of exercise that aren't so, focused on getting people stronger?
Yes, is the simple answer. Flexibility exercises, mobility work, cardiovascular exercises, they all have, a lot of benefits for a human being, both, physiologically and psychologically and mentally and social economically as well, I'm sure of it somewhere down the line. So, yeah, I think, there are lots of different variations of exercise and activity that you could use to help somebody with their problems and their disabilities. I just think there are some populations that are better off served by doing resistance-based exercises, I've already mentioned, so yeah. I'm not going to say it's the only option, but it is a good option for many people.
For sure. Okay. So switching gears again, we've spoken a little bit about things like self-efficacy, people's beliefs, and that when people get better, it's not so one-dimensional. It's not always because of purely biological factors. And this shift from the idea that we're only treating the biological factors to we're treating the whole person is the shift from the biomedical model to the biopsychosocial model. I've heard a criticism from people say that we shouldn't be focusing on psychosocial factors because physiotherapists are not psychologists. We're not trained in treating people with depression or anxiety. I swear I've heard this.
I have as well, mate. Yeah, I've heard it as well. Yeah.
Yeah. And I know some friends have as well. So some people say that's out of our scope of practice, and we have to stay within our training and only focus on the body. So first off, what are your thoughts on that? And secondly, what does it mean to integrate the biopsychosocial model into your practice?
You know, you should get on for your second podcast to discuss this a bit more. Will be my good mate Ben Cormack.
I was honestly thinking about that today after his self-efficacy post. I might send him a message after this.
Yeah, I will also send him a message and say, go on Noah's podcast and explain this question that he's just asked me, because I'm sure I'm going to do a very bad job of it and he would probably do a better job of it.
Right, so he just helped write a paper on this, right?
Exactly right. So he's just got a paper published this year exactly on this topic. And you know, he will say, and he's right, that the biopsychosocial model has been abused and bastardized in musculoskeletal healthcare to something that Engel, who came up with it, wouldn't recognize and wouldn't be an advocate of at all, because it is used very poorly to explain what the biopsychosocial approach is. You know, but I do agree with these critics of the biopsychosocial approach. They are right when they say we are not psychologists. We are absolutely not psychologists. We are not trained to deal with psychopathology. So when people do have a pathological psychological condition, you know, severe depression, anxiety, that is absolutely out of our scope of practice. And any physiotherapist who's dabbling in that is outside of their scope and probably being unprofessional and probably doing more detriment and harm to the patient than probably benefits. However, you don't need to be a psychologist to be a caring, empathetic human being to tell people who are a bit frustrated and upset about what's going on and a bit down in the dumps to, you know, give them a bit of reassurance and just to be a soundboard and a reassuring ear for them to express their frustrations to, or say, how are you feeling today? You know, and there's that is just being a caring, empathetic human being working with somebody who has got some concerns and some issues and some problems. And that's not being a psychologist. That's just being a good patient-centered healthcare professional. And that's where I think, you know, the biopsychosocial model is trying to tell us what to do. It's about saying, you know, when people come in with their musculoskeletal conditions, yes, treat their musculoskeletal conditions, focus on that, but recognize the person that's attached to those musculoskeletal conditions and all the frustrations and the anxieties and the issues and the concerns and the fears and the doubts that they're going to have with it, and manage that as well. And again, you don't need to be a psychologist to do that. You just need to be a normal, caring human being, which I find some physiotherapists struggle to do sometimes.
Yeah, beautifully put. Yeah, just it's this weird way of targeting the biopsychosocial model with this assumption that it means that we're trying to cure someone's depression or anxiety, which is not the point of it at all. And your other buddy, Greg Lehman, I took his course and it was wonderful. And I loved what he said in it, which is that you're not telling someone that their depression needs to go away in order for their pain to go away. That's not the point of the biopsychosocial model. It's not saying that this person needs to be perfect mentally in order to be perfect physically.
It's moving away from that fixer mentality with these psychological, sociological problems that people come in with. Just as we've moved away from this fixer mentality with the biomechanical structural problems, we need to do the same thing with the other factors as well. We just need to move away from that fixing mentality and be this person that is there to advise, guide, reassure, just be a soundboard for people to express their concerns and their issues to.
Yeah. Just being a caring person, as you said. Absolutely. It's
I have the same argument as well with people. I say, you know, okay, let's say you're talking to a patient who comes in with some knee or back problems and they're overweight. and they say to you, I'm sure it's been because I'm overweight. That's why I've got back pain. I know I need to lose a few pounds. Could you help me out here? Could you give me some advice on how I could go about doing that? Are you going to say, excuse me, I'm not a dietitian. I can't possibly give you any advice here. Of course you're not. You don't have to be a dietitian as a healthcare professional working in a musculoskeletal practice to help somebody lose a few pounds if they ask that's something they want to do because they also think it's causing their problems and their pain. It's just that sort of same mentality with people that are depressed or anxious as well. You don't have to change it. You just have to help them and recognize it and talk to them about it.
Yeah. And that doesn't mean that there's just like there is a way that you could help someone who is obese who wants to lose weight. There is a way that you could help someone with depression. It's just by maybe trying to make them laugh. It's not that you're trying to cure it clinically, but just, again, not just being that sounding board, but also just being someone in their life that's a positive person can be helpful.
Just validating it for somebody is a huge treatment. It's just talking about it. It's just recognizing that there's this elephant in the room. Some people just want to vocalize it and they just want somebody else to understand and accept that this is the problem that they've got. And they don't want, magic answers and solutions. They just want somebody to validate that they're going through a fucking tough time and a period. So just accepting that and just acknowledging that can be a huge help to a lot of people.
I agree. Where's the line though, Adam? So when someone starts opening up to you about their depression, where do we have to draw the line? Do you think there's a hard point where we could, draw a line in the sand, where we say, now this is out of my scope of practice?
Not really. I don't think there's a black and white line that's hard here. There are shades of grey. But anything that makes you feel uncomfortable, anything that makes you feel like you're uncertain about how to proceed or what to say, then I think you're going to need some further assistance and support. So I have been in some situations where people have been talking about, self-harming, or a couple of situations where people have said they felt suicidal. That is way out of my practice, But the first thing I do is recognize that and validate that for the person. When they told me these things, I'm making sure that I accept and I make sure that they're aware I've heard what they've said, and then I will appropriately act and say, but I think we need to get somebody else involved here to help you out if you're willing to do that, because I think, there's some other things here that somebody else may be able to help you with far better than I can do.
Right.
Are you prepared, or are you happy for me to do that? Can we take those next steps and take it from there? So my advice is always, whenever you feel out of your scope of practice is when to stop trying to be in that practice, is to seek advice and guidance for somebody else, go and find somebody that can deal with the situation better.
So some self-awareness there is key.
Absolutely. Not trying to solve everything and feel like, again, it's a weakness to ask for help. It's not a weakness to ask for help. Let's say if you're working in a clinic and you've got a senior, the first person to talk to is the senior. After, you've spoken to the patient, go and speak to your colleagues, ask for some advice and see if they can help you out, and then signpost you onto the other people that they may know as well. So don't feel ashamed or embarrassed to ask for help.
Right. Yeah, we're not superheroes. We can't do everything. So let's try and put this all together. You teach a course all over the world, online as well, about painful shoulders. I haven't taken it yet. I want to, but I'm waiting until you come to Toronto. So I am curious how you got into that in the first place, because when I think of you, Adam, I think of someone who is well-versed in many different topics in MSK Physio, who's knowledgeable about many things, and who is just able to communicate these things. I find it interesting that you focused on the shoulder, for example, because when I think of Greg's course, for example, he has this more broad scope. Now, with that said, I'm sure that everything that we spoke about today so far is somehow integrated into your course. So let's say someone has a painful shoulder. Are there any key tenets that you will bring into play when you're dealing with those sorts of people?
No, again, I'll go back to that answer I said earlier. It's not about the pathology. It's not about where the pain is. It's not about the structure of the body that hurts. It's about the individual. So, it's all about, this listening to the person, this, not their, where their problem is and where the problems are as to what guides or, decides has to be done. It's a person patient centered approach. That's the key factor here. But I agree. First of all, I'm going to say thank you very much for giving me that glowing synopsis there, that you find me grounded in all areas. It's very kind of you to say so. You've made my ego increase by about 3 points there. So great. Thanks for that.
My pleasure. I know it was needed.
Yeah. No, it's not. But yeah, why did I get into the shoulder? It was a complete accident, if I'm being honest, mate. I had absolutely no idea to specialise in any one part of the area. I was going to be quite happy and content to be a generic physiotherapist, a general musculoskeletal physiotherapist. And I still class myself as one, but I've just got a little bit more of a specialised area and knowledge in the shoulder. About 80% of my caseload, I'll say, is painful shoulders, and the other 20% is a mixture of back, knees, hips, little fingers, etc. But yeah, complete accident, just because of the environment and the situation I was in. I got asked to start specialising in the shoulder when I was working in a rather prestigious private hospital that was well known for having some very well-respected international shoulder consultants who just wanted a dedicated physiotherapist to look after their complex cases. So they said, "Do you want to start specialising in the management of the shoulder, Adam?" And I said, "No, thank you. I'm much more interested in ACLs and knees and sporting things, not shoulders."
Yeah.
But they persisted and convinced me, and say probably 15 years ago, around that time. And yeah, I just sort of started to focus a bit more on my reading and my attention, and obviously my caseload changed with more shoulders coming in. So I just started to get exposed to more shoulder pains, and it just went from there. But as I said, my principles of treating somebody are based on not just where their pain is and what their pathology is, it's based on the individual. And so, I treat people with back pain and knee pain no different than I do when they've got shoulder pain, really, a lot of the time.
Right. So I guess to sort of summarize, I guess your course would be that you are taking key tenets of how you typically would treat a whole person. And it just happens to be that they have a painful shoulder, which you have specialized knowledge in about the biological aspects of the shoulder and certain conditions that you might see there, like frozen shoulder, like rotator cuff related pain.
I use the painful shoulder as a sort of vehicle to talk about the key principles of how physios, or how I perceive physios, should be in this, evidence-based world of trying to assess and manage and treat and practice. And, in the first 2 lectures of my course, the first morning, that we don't even talk about the shoulder. A lot of people are like, on a painful shoulder course, we haven't even mentioned the fucking rotator cuff yet. What about where's the glenohumeral joint? We haven't even discussed that yet. And I'm talking about, principles. I'm talking about, things to be focusing on, and your assessment and engagement and communication skills, because these are the things that are lacking in our education system. We get taught a lot about the exercises and the anatomy and stuff, but we get very little advice or teaching on how to communicate and talk and connect and reassure and motivate and facilitate people with our words and our language. And that for me is something that, as I say, hugely, hugely helps me get good outcomes with patients. It's not about what I'm doing. It's about how I connect and communicate with a person. And so I spend the first morning of my course going through those key things.
I'd love to see those confused faces, but they should know that if they're getting into it with you. Individualization is key. Is that why everyone in the course is always squatting with their hands in the air at the end of the course?
That's just so because I like everybody to look like they're praying to me. So every course I do, it's just the why I get so many messages when I post those videos out on social media going, "Oh, you're such a guru, making people do praying in front of you." I'm like, "Yep, exactly what I do." just to get that trigger and that little troll out there to get all agitated and send me a little message.
That's funny. If anyone doesn't know what we're talking about, follow Adam on Instagram, watch his stories, and at the end of all of his courses, he gets all the participants to do a bunch of squats with their hands in the air. It's very funny. It's very funny. Adam, if you were to go back in time and maybe start your career over, is there maybe, I don't know, 100 years ago or so, would you... Is there anything that you would want to tell your maybe 20, 25-year-old self?
Don't do it. Stick with the strength and conditioning. Personal training would have been so much more better. No, I'm joking. What would I tell my younger self? Perhaps don't be so naive, but that's easier said than done with hindsight. Although I've always been critical and skeptical, I got hoodwinked by a lot of the gurus out there and the dogma and the mentality that you had to, not question and just listen, and you had to give it time before you earned the right to be able to challenge and question and critique things. So I'd have perhaps told my younger self is don't fall for that. Try to have a little bit more confidence in your ability as a human being, as a critical thinker, regardless of your age, regardless of your experience, to be able to question and challenge things. So I think that's the main thing I would probably tell myself. And then I think, the other thing is don't beat yourself up for not helping everybody you see, because I got very, very pissed off with that. Because, again, I was disillusioned and fed a lot of bullshit about what to expect going into practice. And I saw a lot of people that I thought this should get easier very simply. This is a condition that should, be a walk in the park. This patient should get better in 6 to 8 weeks, and they don't. And I'm like, I'm a failure. I haven't done a good job here. It's my fault here. And over the years, I've just realized there are so many things outside of our control that do or don't dictate whether somebody improves. So, a saying I say is don't celebrate your successes too much, because people have got better because not of what you've done, but don't get too demoralized with your failures either. So, it's just trying to find that balance of, say, not thinking you're the God's gift because people are getting better, and not sort of thinking you're the worst physio in the world because people aren't getting better. Try to keep the balance, try to help as many people as you can, but just realize there's a lot of factors outside of our control, as I say, that do affect patients' outcomes. And as I say, don't take it too personally, and don't get demoralized with those losses and those failures, because it will play on your mind quite a bit. I've had many sleepless nights thinking about patients' cases and caseloads, and I still do, thinking I could have done that bit better, I could have said that a little bit better, I could use a better metaphor there, I could have tried a different exercise. Why hasn't that patient come back to see me? I've tried calling them and they're not answering, they're not replying back to my emails. Is it me? Have I said something? And you can beat yourself up a lot over that sort of stuff. And I think, again, my advice to young students is, don't get too flippant. Don't just think you don't have to think about these things, but don't beat yourself up too much about it.
Yeah, that's really good advice. I know for myself, it hits close to home, and it's something that I struggle with. When someone compliments me, a patient compliments me and saying, thank you so much, the first thing I try and do is deflect it back onto them. Like, well, you did this, you should be proud that you changed your mind about this, or that you did these movements and exercises. But when something bad happens and someone's not getting better as quickly as that, exactly, it's my fault immediately, which in a way, not to put more blame on myself, but in a way it's almost self-centered. You forget that there's so many things at play here. So when I do that, when I go into these negative thought patterns, I actually do think of what you just said, because I've heard you say it before. So I appreciate you putting that out there.
For getting there and thinking like that, mate, because I wish more physios did. So kudos to you for getting there.
Well, I'm standing on the shoulders of giants. It's not like I came up with everything. I spend a lot of time listening to people like you, like your colleagues. So, I have you to thank
as well. I very much say the same thing as you just said there. Everything that I'm saying and done has been said by excellent physios were before me. My greatest mentor, my greatest influence as a physio and the way I practice now, God rest his soul, Louis Gifford. He was the person that was very much me 20 years ago, and there's many others out there. Max Zussman as well was another one. These physiotherapists back in those early 70s and 80s, doing all the things that we are trying to say now, and still coming up with the same problems and the same barriers and the same issues back then. which, when you think about it that way, can be quite demoralizing.
Yeah.
But, it's good to recognize, as say, people's the struggles and the problems they've had in the past, and to say that we're carrying the mantle forward and we're trying to change and move things. And it is, and I can see it changing, from what Louis was doing compared to where we are now. And I'm sure what you guys are going to be doing in another 10 or 15 years, it is moving in the right direction. It's just so fucking slow.
It is slow.
It is ice age progress, that glass, well, not with this fucking global warming shit that we're going through at the moment, but the processes are just so very slow, but it is shifted in the right direction, which gives me hope and positivity and keeps me going.
Yeah, that global warming stuff will move at a quicker pace than
physio. I've got a feeling that will sort all of our problems out probably sooner than we'll sort our problems out anyway.
All right, should we end on that high note?
Yeah, that's on the end of the world and the end of population and civilization as we know it. That will sort all the problems out. Let's call that podcast a wrap. Yeah.
Lovely. Have a good day, everyone. Adam, where can people find out a little more about you? Where can they follow you, and where can they tune into your upcoming boxing match?
Well, I'm a shy wallflower, actually, Noah, so it's very hard to find me. So I don't think anybody's going to be able to fight. No, I'm joking. I'm all over social media, so you just normally have to just put my name, Adam Meakins, into Google or the Sports Physio, and you tend to find me. But I'm on all the social media platforms, Twitter, Instagram, Facebook. I'm even on TikTok, although I don't bloody use it because it drives me crazy with all the dancing and the jingles and all that sort of shit. I've tried to do a little bit on there as well, so you can follow me on TikTok as well if you want to. But no, mainly Twitter and Instagram are my two main two. And I've got my webpage as well, which is thesports.physio, which has got a bit more information about me, etc.
A lot of good stuff on Spotify as well, or Apple Podcasts with the NAF, the NAF Physio podcast as well.
Yeah, we're on a temporary hiatus at the moment due to some stuff that's going on and work commitments as well. So we haven't done any NAFs this year. We're probably going to take the rest of the year off, I think, and it may be restarting in 2024. But there's 75 issues, I think, or episodes on there for you to go through the back catalogue if you want to listen to me.
Yeah, a lot of good stuff in the history. There's a lot of good stuff in there. So
appreciate that, Noah. Thanks.
Yeah, my pleasure. All right, Adam. So thank you very much for coming on. I really, really appreciate it. I hope everyone learned something. I know I did. So thank you very much.
Well, again, I'm going to say thanks to you, Noah, for inviting me on, and please keep on keeping on doing what you're doing. It is really encouraging to see young physios coming in, fresh out of university with this attitude and mindset of critical thinking, humility, honesty, humbleness, all of these things. It is really, really encouraging. I've got all the time in the world to support young grads and new clinicians with that mentality. So again, please keep on doing what you're doing, mate, and keep trying to change the world one patient at a time. Yeah,
will do, even if it takes that glacial pace.
Absolutely.
Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember, when life gets you down, you can recover stronger.